Quick review though. So we're third or fourth week into arrhythmias. So we started with the SA node, right? So we had our SA node arrhythmias. So your sinus rhythm, your normal sinus rhythm is the rule follower, right? So rate, rhythm, P wave, PRI, and QRS, right? So my rate was between 60 and 100. My rhythm was regular. My P wave was positive, rounded, identical to the others. My PRI is 0.12 to 0.20, or 120 milliseconds to 200 milliseconds. And then my QRS, I don't have a real deep Q wave. My QRSs are looking like the other QRSs, right? And my interval is 0.12 or less, right? So if it follows all of those rules, then it is a normal sinus rhythm. Then we went to sinus Brady, where it was a rule breaker.
Under 60.
Yep, the rate under 60. Sinus tachycardia is a rule breaker.
Over 100.
Over 100. With sinus tachycardia, what is the key to managing sinus tachycardia?
Managing whatever's causing it.
You got to figure out what the underlying cause is, right? Because it could be a metabolic issue, fever, maybe an endocrine issue. More commonly, it could be a hypovolemic issue, dehydration. The body's trying to compensate one way or another. So we learned early on that the body actually tries to increase cardiac output, and it all goes back to cardiac output, right? The body tries to increase cardiac output by increasing heart rate. Remember, stroke volume times heart rate. And it tries to compensate by increasing heart rate. So then we went to sinus arrhythmia or sinus dysrhythmia, rule breaker there. It's just, what?
It wasn't regular.
It wasn't regular. As long as it's got a good rate and it's perfusing, we're not worried about it, okay? Then the last one that we talked about with our sinus rhythms was sinus arrest. We do kind of start worrying about sinus arrest, because for whatever reason, the SA node has decided that it's not going to fire. Most likely it's decided against its own will, but it is not going to fire. The more frequent we start seeing those periods of arrest, the more ominous it is. So then we moved on down to the atria. So one of the things that we got to remember about the atria and atrial arrhythmias is that the P waves are going to look different, or there might not be any P waves. Some P waves are going to look kind of weird, like your atrial flutter waves. Some of them are going to look different in at least 3 or more, like your WAP or MAP, right? But we're going to look at P waves, we're going to look at regularity. So the first thing that we talked about was not really a rhythm, it has an underlying rhythm, and that's a premature atrial complex, right? So most of the time you're going to identify the underlying rhythm as sinus rhythm, and then you're going to identify the complex because it's going to show up before the next expected beat, right? So sometimes they'll have what's called a non-compensated pause, right? Where pretty much the SA node gets kind of reset and then it has to start getting in a rhythm again. Sometimes it has a compensated pause. So the main thing that we're going to look at that's going to identify it as a PAC is what?
Before it's supposed to. Or
All right.
you believe the next beat's going to do.
All right, so the complex arrives before the next beat should, and then physically, what is it going to look like?
Right on top of the T-wave, right?
Well, it could be close. It's not going to be right on top of it, but what is the P wave going to look like? All right, so it's not typically going to be inverted with a PAC, but it's going to look different with your sinus rhythm. It's going to look different than your SA node P wave, right? Your SA node P wave should be smooth, rounded, upright, should be identical to the others. And then with your PAC, it's going to be a ectopic beat that arises from somewhere outside of the normal pathway, okay? So then we move to atrial flutter. You got your sawtooth pattern. So you have a reentry pathway or a short circuit that's caused in the SA node, or in the atria, I'm sorry, and The AV node is essentially acting as a gatekeeper. We're going to talk about that a good bit, and today especially with the AV node being a gatekeeper. But you start seeing those tall sawtooth waves, right? It may be a 4-to-1, a 2-to-1, a 3-to-1, and then eventually you have a Qrs complex. Now remember, while we're in the SA node, the atria, and even if we're in junctional rhythms, as long as the QRS is unaffected, it should look normal on your complex. Then, of course, when we get to the ventricular rhythms, like we talked about last week, it looks a little different, right? Then we had atrial fibrillation. So a couple of key things about atrial fibrillation. There ain't going to be a P wave, and it's going to be irregularly irregular, and the baseline's going to look fibrillating. So essentially what's happening here is that your atria, the cells are fibrillating. They're not creating a good axis of depolarization. And the AV node is essentially holding up the smaller conductions until it allows a good axis of depolarization to go down, okay? But there's no predictability to that, right? You don't know when the next complex is coming. That's why it's irregularly irregular, okay? Then we talked about SVT. More particularly, the textbook SVT, that when we talk about SVT, narrow, QRS less than 0.12, greater than 150, 160, regular, no P wave. Most of the time, you're looking at something like an AV nodal reentry tachycardia. Basically, you've got that same short circuit that we were talking about with the atria, but now it's at the AV node, and it's just continuing to fire. It's supraventricular. That's why it shows up in the atrial arrhythmias. It's not a junctional, not always, because you got a tachycardia in the junction. It looks very similar, but it's not, and it's not in the ventricles. So we know that one of the ways that we would want to slow this down if they were stable is what? We would give what? Well, the first thing we would try to do is what? We'll try to get them to vagal. The next thing we're going to try to do is give adenosine. So where does adenosine focus? What node? AV node, right? So what does adenosine do? What does it do to the conduction as it goes down the AV node? It slows it down to allow for those fast potentials and slow potentials to eventually kind of crush back into each other and dissipate, right? Remember the video? It said, and it goes up in a cloud of smoke, but not really a cloud of smoke, ha ha ha. I thought it was funny. Your SVT, so if it's stable, and when we're talking about stability, we're talking about hemodynamic stability, right? Pink box of death. We don't want them to have any of the issues in the pink box of death, hypotension, signs of cardiac compromise, that kind of stuff. If they are unstable, then we're going to immediately go to what? Cardioversion. Cardioversion. All right. So while I'm talking about your tachyarrhythmias, let me back up to AFib really quickly. AFib RVR. We talked about that. AFib with a rapid ventricular response. So in this case, you're having those fibrillating cells, right? And the AV node is just allowing more conduction to go through. Remember, the ventricles are, in theory, relatively healthy compared to the atria, and so they're going to respond to whatever is thrown their way. Now, one of the big differences that you're going to try to identify between atrial fibrillation, RVR, and SVT is irregularity, right? But sometimes you may not be able to. And in this case, you may give adenosine, and it may end up being used as a diagnostic tool. What do I mean by that?
When it's supposed to hurry down, you can see the AFib.
So your adenosine is still going to slow the conduction through the AV node, but if it's an arrhythmia originating in the atria versus a conduction issue, then it's not going to make those cells depolarize, but it's going to slow the conduction down, and hopefully it'll be enough where you can see the irregularity, right? So if that's the case, then we may need to move to something else like diltiazem. What kind of drug was diltiazem? You ever remember?
Calcium channel blocker.
It's a calcium channel blocker, or amiodarone. What kind of drug is amiodarone? Antidysrhythmic. What class? 3. Class 3. Class 3. Okay. So we got in our atria, we've got our PACs, we've got our A-flutter, we've got our AFib, we've got our SVT. Oh, our wandering atrial pacemaker. Wandering atrial pacemaker.
Okay. Didn't have to have all three different P waves.
Yes. So what's happening in wandering atrial pacemaker?
It's just one.
AV nodes firing from different sites in the atria.
All right, so the pacing is occurring at different sites in the atria. And so because they're originating from different cells or different pacing sites, the P wave's going to look a little bit different. And remember, when we were talking about cardiac monitoring, the main reason why is because the camera, aka the lead, is just getting a little bit of a different vantage point, right? If they're all coming from the SA node, I'm going to get the same picture over and over from the SA node. But if they're coming from here and then here and then here, I'm going to have just a different vantage point as to where I'm looking at that. And so the lead 2, your positive in lead 2 is going to pick up a little bit different with each P wave because it's arising in a different area. Okay? So what was the difference in WAP and MAT, multifocal atrial tachycardia? Yeah, so it's the same rhythm except MAT is just over 100. Okay? All right, then we move on down to our AV junction. So something's happened at the SA node, the AV junction has decided it needs to start pacing, right? So one of the things that we're going to notice about that is that if it is a junctional escape rhythm, we're not going to have a P wave, or it's going to be inverted, or it possibly could be after the QRS, but for it to be just plain junctional escape rhythm is going to be what rate?
Between 30 and
40 and 60. 40 and 60. All right, so what if I have the same rhythm, but it's going at a rate of 80? Accelerated. So what are the parameters for accelerated junctional?
60
to 100.
100.
Yep, the same rhythm, 60 to 100. And then what are the parameters for junctional tachycardia? Over 100. So it's really easy, especially when it gets up into a higher rate, to confuse junctional tach with what? SVT or supraventricular tachycardia, which essentially we're going to treat the same. Okay? And then the other thing that we talked about was the premature junctional complexes. So with premature junctional complexes, it gets a little bit easier to identify because they're either going to be a flipped P wave or we're not going to have a P wave, correct? Remember that?
What were you talking about? Didn't have it was flipped or didn't have one?
Yeah,
No, I
you're,
had said that I was wrong.
yeah, with,
No, with the regular junctional rhythms.
yeah. But then your junctional complex is still arising from the same area. It's just not a regular pace. It's a ectopic beat that shows up. So it's going to look the same as the complex that's in a junctional rhythm, except it's just going to show up with an underlying rhythm of usually a sinus rhythm. Okay? So we'll identify that with the same parameters that we identified the PAC, except we're looking at the P wave, and it's going to either be flipped or no P wave at all. Okay? So then we moved on down to the ventricles. So with ventricles, what's going to be the main thing that we're looking at for it to determine if it is in ventricular origin? Yeah, so you're going to have a wide QRS. It's going to be greater than 0.12 or 120 seconds, okay, or milliseconds. So with that, we talked about a few of the PVCs. They're easy to identify. I'd say the PVCs are the easiest premature complexes to identify. We're looking for a complex that shows up with an underlying rhythm. It could be of the same morphology, but it's going to be wide, and that would be unifocal. It could be of a different morphology, and that would be multifocal, meaning that they're coming from different sites of origin. It also could be bigeminy, where every other beat is an ectopic beat. Trigeminy, where?
It's 2 normals to 1.
Yes, so 2 to 1, or quadgeminy, 4 to 1. Sometimes you'll have 2 together, and those are called couplets. They're a cute little couple. They decided to dress the same that day. Or you could have a run of ETAC where it's going to be more than how many? 3. Okay. Then we moved on to idioventricular. Idioventricular, we're looking at a rate of what to what? 20 to 40. 20 to 40, right? Because 40 to 60 is your junctional, 20 to 40. That's why I had y'all learn the intrinsic pacing rate of the SA node, the AV junction, and then the Purkinje network, okay? So if the ventricles have to start pacing, this is kind of a last-ditch effort, right? And so we're going to notice a big wide QRS. There's not going to be any atrial action there. Once that wide QRS starts dropping below 20, we're going to call it a what? Agonal rhythm, okay? What if you've got an organized wide complex, but it's at a rate greater than 100? Greater than 100. Ventricular tachycardia. Y complex greater than 100, okay? Y complex greater than 100. But one thing that you got to remember about ventricular tachycardia versus ventricular fibrillation is that ventricular tachycardia can have a pulse, or it may not have a pulse, and it's going to be organized on your readout, right? Whereas ventricular fibrillation is just a bunch of quivering and shaking, and so all it's showing is that in reflection on your monitor, okay? So with your ventricular tachycardia, we determined that they do not have a pulse. So what's the very first thing that we do? Even before we shock them. Immediate CPR, and then we immediately shock them, okay? We want to try to defibrillate as quick as possible. Same thing with ventricular fibrillation. It is key that you get defibrillation very quickly, okay? It is key that you get defibrillation very quickly with these, all right? Then we also talked about torsades de points, twisting at the point. So basically you have a polymorphic ventricular tachycardia. It's still going to have a little bit of organization to it, okay? A lot of times that's because of an electrolyte deficiency. We can give what drug? Mag sulfate, 1 to 2 grams of mag sulfate for that. And then of course we went into a systole, which is absolute absence of what? Any electrical activity. Or, yeah, in the ventricle, because sometimes you could have a little P wave, but it don't really matter, right? Or you could have pulseless electrical activity, PEA. So remember I told you the old term, and I kind of like it, it helps me remember, is electrical mechanical disassociation. Remember you have two functions of your heart. You have your electrical and you have your mechanical, and the electrical needs to contract or create a conduction in order to cause the muscle to contract, right? So something's happening and the electrical is still showing up, but it's not stimulating the heart muscle to contract, okay? And then we would treat those two with the cardiac arrest, the systole PEA algorithm, where we essentially give epi as soon as possible, CPR, epi CPR, epi CPR, airway if possible, epi CPR, all right? One of the things that I do want to remind you about a systole is that you've got to use your discretion. How long have they been down? Do we have presumptive signs of death? If we don't, how long have they been down? What is their comorbidities with a cardiac arrest? Because most of the time, if somebody's in a systole, they're going to be in a systole, okay? But if you are lucky enough, or the patient's lucky enough that you're able to get there and they're still in a shockable rhythm, then we want to shock that very quickly before we lose it, okay? All right, so we've made it anatomically through the heart, but we need to put it in reverse, Terry, and back up just a little bit. We need to go back to the AV node just a minute. So I keep referring to the AV node as kind of like the gatekeeper, right? Because we know that it does actually differentiate between what conduction goes down to the ventricles and what doesn't, right? We know that one of its main functions is to allow for ventricular filling, so it holds up that conduction for a very small amount of time. I think it was like 0.05 seconds. But that allows for that conduction, and we see that on the strip as the PRI, right? So we're going to talk about some issues with PRIs today. So when we're looking at AV blocks, we're going to really look at the PRIs to determine, what type of block it is. But we're also going to look to see if you've got a P wave for every QRS and a QRS for every P wave. So this is where some of those answers are going to come in. Remember when we were talking about the P waves, I said it don't make a lot of sense right now, but as we get into some of these arrhythmias, you'll understand. You have a P wave for every QRS and a QRS for every P wave. So, if a blockage or delay develops at the AV node, the impulse will be a partial, incomplete, or a complete block. Now, you may also have a delay, and the very first heart block that we talk about is really more of a heart delay. Okay? Rhythms that are primarily disorders of the conduction system are called heart blocks, and that's where we're going with this. So the very first one is first degree AV block. First degree AV block. So it's the most usual form of heart block. This right here, it results from an excessive conduction delay in the AV node. So we know that a normal PRI should be what? 0.12 to 0.20. How would a delay in the AV node show up on the EKG?
An extended PRI.
An extended PRI. That's the only way you're going to identify first degree AV block. Is the PRI greater than 0.20? Remember, we got to look at our rules and figure out which rule is it breaking. Now, sometimes it may be a rate that's bradycardic, and so there may be a couple of rules that it breaks. But generally, a first degree AV block is not treated just as first degree AV block. You're not going to say, I'm treating a first degree AV block. Most of the time, you're going to treat the underlying bradycardia, okay? The other thing that I want to go ahead and get in your mind right now about your first degree AV block is that it is the only block that will have a underlying rhythm, okay? So just like when we had a PVC and we said sinus rhythm with PVC, that's what, if you identify first degree AV block, is going to be sinus rhythm with first degree AV block. That's the only one. We're going to talk about several more AV blocks, but the first degree AV block is the only one that you identify an underlying rhythm. Okay? So if you just look at the very first one, and I put it on your outline that I did not hand out to you guys. How about I give you one of these? Pass it all the way back. Now, unfortunately, these are the only outlines I have. I don't have outlines for the pace rhythms and stuff today. All right, but go ahead and open up your package if your packet, if you're following along with me, to that first rhythm. So on this rhythm, I've identified the P wave, the T wave, and the QRS. So one of the reasons why I wanted to identify the T wave is when you're first learning, I know that sometimes you struggle, but remember, your T wave is going to be bigger than that P wave, okay? But if you notice where the P wave is in relation to the T wave, it's not very far from it, right? But you would measure that PRI from the start of the P wave to where you start going up on that conduction, and I don't know what it is. Just looking at it there, it's hard for me to tell.
Okay, so I'm struggling.
It's a lot.
I'm struggling with the complexes where if the P wave's after the QRS,
Mm-hmm.
so will the T wave will always be bigger than P wave no matter what ring?
Yes, and most of them aren't going to look like this.
Okay.
But if I were looking at this, I would start my measurement of the P wave like right there. And I would end my measurement of the PRI like here.
We don't see anything like that.
Green.
It's the teal.
Well, the teal is a highlighter. Right there. All right, but they're not all going to look like that. So, your first degree AV block, I've already mentioned this, is not actually a dysrhythmia within itself. Is present indicates a delay. So, in reality, it should be called a AV delay instead of an AV block, okay? It will have an underlying rhythm. You got to remember that. It will have an underlying rhythm. Sometimes it may just show up. Folks that have no history of heart disease, sometimes seen in young adults, can be caused by beta blockers because they will slow some conduction. Sometimes they'll have dromotropic effects, calcium channel blockers, and digoxin. So the hallmark of this rhythm, though, is that everything else is going to look pretty much normal. The rate may be a little slower, but your PRI is greater than 0.20. That's it. In order to identify a first degree AV block, you just need to identify consistent, they got to all be the same, PRI is greater than 0.20. Okay? So your rate's going to be based on your underlying rhythm. The rhythm's usually regular. There should be a P wave, or there is a P wave before every QRS, and there is a QRS for every P wave. That's important. The PR interval is going to be greater than 0.20 seconds. If it's less than 0.20 seconds, it's not a first degree AV block. And then the QRS should be fine. Should be less than 0.12. Okay? So here we go. Here's one right here, all right? So the first thing that we want to do is we're going to find our P wave, our start of our P wave. And we're going to measure from right there to right there. Can y'all see the teal?
Yes.
There you go. The teal works.
I know it. I'm telling you, that's the trick.
So what is the PRI on this one?
0.28.
I got about 0.26 or so. Okay? So, if I were to ask you which heart block that we're going to learn today has an underlying rhythm, you're going to tell me
First degree AV.
first degree AV block. And if I were to ask you what the hallmark of the first degree AV block is, you're going to tell me PRI greater than 0.20. That's it. That's it. Okay? So in this situation, think of the electrical conductions made at SA node, atria, then they make it to the AV node, and the AV node, I kind of imagine it like when I played football and we were trying to run and everybody had the tackling dummies right there, and we were trying to run through and it slowed us down every time, but we finally broke through. And that's kind of what's happening there with the conduction, right? It's made it to the AV node, okay? But it's slowing down, trying to make it through, and then it finally breaks through, but it takes longer than normal, okay? Always, always, always identify your underlying rhythm first. So, what would I call this rhythm right here? I'm not asking you to do all the steps, but what would I call this rhythm?
Sinus rhythm with the first degree AV.
Exactly. Sinus rhythm with first degree AV block, okay? So now we're going to get into second degree heart block type 1, okay? Notice type 1, because we're going to have 2 second degree AV blocks, okay? So go ahead and open your mind up just a little bit more to fit another type or another second degree in there in just a moment. Your second degree heart block type 1, this is the less serious type because usually it's going to produce enough complexes in order for you to have a perfusible rhythm. Notice the term right here, progressive. Progressive delay. What does progressive mean?
It gets longer.
It gets longer. It gets longer, longer, longer. All right? So I'm going to go ahead and tell you a little rhyme before we even get into it. Longer, longer drop, then you got a winky bop. That's what this is called, is a winky bop. Okay? A second degree heart block type 1 is also called a Mobitz 1 or a Winkenbach. Okay? So it's a progressive delay of the electrical impulse at the AV node that produces an increase in the length of the PR interval. So if you think about that, if it's a progressive, meaning that it's going to take longer and longer and longer for that conduction to go through, what do you think your PRI is going to look like?
Super long.
Your P wave is going to get farther and farther and farther away from your QRS until finally the QRS drops. Okay? So the way I think about this is that I'm trying to get into the club and I made it through the bouncer. The next friend of mine got into the club, he made it through the bouncer. We're underage. It ain't as easy as just showing our ID, okay? My third friend makes it through and the bouncer's starting to catch on, but he dodges them and he gets in. And then that last guy, boom, he hits Big Rocky and he gets knocked out. He don't make it into the club. And then it starts over. Okay? Think of your AV node as the gatekeeper. None shall pass. The PR interval continues to increase in length until the impulse is not conducted or the QRS complex is dropped. And it's going to be repetitive. It's going to be repetitive, meaning that we're not going to be able to identify a PRI that is the same, but it should follow the same pattern. One length, a little bit longer, drop. One length, a little bit longer, drop. Now, are you still going to see a P wave? Yes. So in this case, when we're asking the question, do I have a P wave for every QRS? The answer is going to be yes. But if you ask the question, do I have a QRS for every P wave? You're not. Okay? So overall, we're going to say that the rhythm is irregular. So again, second degree type 1 or Mobitz type 1 is also referred to as a Winkenbach. And it can be caused by abnormal conduction impulses at the AV node, precipitated by AV node ischemia. Digitalis therapy, remember digitalis. Digitalis has that narrow therapeutic window, right? Or increased vagal tone. Typically, though, with this, you've got enough complexes where you're going to be able to perfuse okay. So looking at my rules. The rate, atrial rate is unaffected. The ventricular rate is slower than atrial. Why?
Because it's gonna drop the one at some point.
Yeah, because it's going to drop a complex, right? So we're not going to have a ventricular complex to count. So is there a P wave before each QRS? Yes. Are the P waves uniform and upright? Yes. Remember, it's not affecting the P wave, it's not affecting the atrial conduction, it's affecting just that little door in between the atria and the ventricle, which is going to be identified on the EKG as the PRI. Okay? So the length of the PRI. So if you're identifying this on a quiz or something like that, I want you to put progressively widening PRI. I don't want a number because you can't give me a consistent number. But I want to know that you were able to identify that it was getting wider. Okay? So on the PRI, we don't put NA, we put progressively widening. Because that still is going to give an accurate description of the PRI. Does that make sense? All right, and then your QRS, once the conduction gets to the QRS, everything should look normal, okay? So, if you're looking at the next rhythm, so if we were to just look at this complex alone, it looks normal. But you can already see where it's widening in the next one, right? So that looks okay, but then we're widening, and then, there should be a QRS right there, but there's not. So you got a normal, your PRI is getting longer, it's getting even longer, and then it drops a beat. Okay? What about this one? So notice on this one, you got a normal, and then a drop. So it's not going to be every single type 1 is not going to always just have 3. Sometimes it may have 5 complexes that are getting longer and longer and longer. But where you identify it is that it drops the complex.
See, that one right there, that would have been hard for me to get on a quiz, just because finding out like where the T wave is would throw me off, and I would think that the P wave was the T wave.
Well, you just got to look at your conduction though. It goes there. Now,
Because like it doesn't look like, as soon as it returns back to like what you would consider like your baseline, it shoots back up like it's a P wave, not a P wave. So that one I would have like totally.
well, but you got your J point is there, and so in this case, it's probably being covered up a little bit too. But let me show you another little secret. Let me find my. You see my P waves? They're regular. You see that? So one of the things though that you've also got to, and now this is the first time you've really seen this, one of the things that you've got to look at is that, all right, I'm measuring my R to R regularity, right? Well, my R to R is not regular. So what happened to that R that should be right there? We've got to figure that out, right? And it was dropped in this case.
Will it be every time that the P wave's regular?
Yep. Because remember, the atria is firing, and the atrial rate, the atria and the SA node and the atria are firing. The issue is not there, right? The issue is at the AV node. Okay? So this one, you should be able to clearly identify. Crap. For some reason it don't want to. You should be able to clearly identify that's a P wave. That's a T wave. That's a T wave. So I've got a P, PRI is getting longer, 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 even longer, and then it drops. You see it?
Yeah, that one's easy to see. The other one just looked like sinus dysrhythmia.
Yeah, because like you like the last one that you did, I mean, you said there's the J point, but like on this sheet and right there, I can't tell a J point because it doesn't go down below. It just comes and goes. Like there's no distinctive J point from what I'm seeing. So that's why I was saying that one I would have gotten incorrect because I couldn't have told the difference.
So your J point's kind of like right there where that notch is. You see where I marked? Now here's the problem though, okay? And it's just going to take looking at it and looking at it and looking at it, but not every patient reads a textbook, right? And so you're going to see, like I was going through some today to try to put on here, and there was just some that are really just crazy, you know, that they're not going to look like that. And you're going to really have to investigate and identify. And so that's why you need to know what the parameters are. That's why you need to know what the rules are that are going to be broken, what to look for. If I'm got an irregular R to R, then I need to be able to figure out why is it irregular, right? Good.
So with Trent saying like one of them looked like sinus dysrhythmia, with the PRI changing, is that going to be able to signify that it's not just a dysrhythmia, it's
Yeah.
a
Yeah,
block?
because if it was sinus dysrhythmia, your PRI would be the same. Okay?
And are you wanting us to, so, never mind, you already answered that question, I just forgot about it. Sorry. Because I'm saying, do you want us to measure out, but then I forgot you told us that, just to put on the PRI widening, progressively widening.
All right. So if I were to ask you, what's the hallmark sign on your QR or on your EKG for a second degree type 1? You're going to tell me what?
Widening PRI.
Widening PRI until you do what? Until you drop a QRS. So is the PRI regular on a type 1? No. No. Right. That's right. It's not. You're not going to have a consistently 0.16, 0.16, 0.16. Okay? I'm making that point because when we go to second degree type 2, this is a more serious type heart block. So from here on out, we're going to refer to these as high degree heart blocks. This one, and then we get to complete heart block or third degree heart block, okay? But this is a little more serious, and the reason why is because you have more drop beats typically in this, okay? But one of the hallmarks of this compared to type 1 is that the PRI is going to be the same. Now, notice I didn't say regular because it could be greater than 0.20. But if I've got a PRI, it's going to be the same. Now, when I ask the question though, is there a P wave for every QRS? The answer is going to be yes. If I ask the question, is there a QRS for every P wave? The answer is going to be no. Because the hallmark here is that we're going to have a drop beat. We're going to have a drop complex. Okay? So this occurs when there's an intermittent interruption of conduction near or below the AV junction. Okay? So some P waves are completely blocked and therefore are not followed by a QRS complex. The PRI are constant and the P to P intervals are regular. Okay? So the main thing that you're going to notice about this is that if I were to measure the PRI, which I really can't measure it here because I don't have like the small grid, but it's going to be consistent, but then I'm going to have a P that shows up without a complex. Okay? The impulse is blocked in one bundle branch and has partial block of the other. In this case, you got to think of the AV node is not just going to allow some to go in, it's just going to take a little bit longer. It's going to allow some to go in and it's going to stop some at their tracks. Okay? So it's going to allow some atrial conduction to go in, but it's going to stop the other So if the gate is open, if the AV node is open, then you're going to have a conductive complex. If the AV node gate is closed, you're not going to have a conductive complex. So sometimes you may notice a ratio. Now sometimes on a 6-second strip, it may not be real easy to get the ratio, but the shorter the ratio, the more severe it's getting. So if you're telling me that for every 2 beats, I'm dropping a beat, I'm going to have more frequent drop beats, right? For every 4 beats I'm dropping a beat, it's not going to be as frequent as that, okay? The atrial rhythm's regular, just like with the other. The PRI is going to be the same, but you're going to have conductive beats followed by drop beats, okay? Associated with AMI, septal wall necrosis, acute myocarditis, maybe advanced artery disease. And again, depending on the ventricular rate, which is going to be dependent on the ratio, it may be symptomatic or asymptomatic, okay? So your atrial rate is going to be regular. Your ventricular rate may be bradycardic, especially if it's a lower ratio. The atrial rhythm is going to be regular. Your ventricular rhythm, because your R to R is disrupted, is going to be irregular. Is there a P wave before each QRS? Yes. For the P waves that are conducted, they're upright and uniform. The length for the PRI, notice it says constant for conducted beats. It doesn't give you a parameter of length. Because if it's a more severe block there, it's probably going to have a harder time even for the ones that are going through to go through. Okay? So
on these, when we're answering them, when we're doing our rhythm strips, do you want us to do the length of the PR interval?
Yeah.
Okay.
Mm-hmm. Because they are constant, so you will be able to do the PRI. So, if I were looking at this one, I'm already noticing that I've got more P waves than I got QRSs. That's easy to identify, right? Now I know it's not a sinus arrest, right? Why is it not a sinus arrest? Because there's P waves. All right? So I'm going to go and look at my, I'm going to go look at my PRI here. All right, so my rate, my atrial rate is higher, 1, 2, 3, 4, 5, 6, 7, 80. My ventricular rate is 50. Okay, so I know that something's off there. There's more P waves than there are QRSs. My regularity, my R to R is irregular. My P to P is regular. My P waves, the ones that are, well, they're conducted, they are normal, they look normal. But my PRI, it's constant. Okay? So it's not progressively widening, it's constant, but then I notice drop beats right here, and right here, and right here. Now, remember when I said just a minute ago, sometimes on a 6-second strip, it's hard for you to determine what the ratio is, okay? I'm assuming this is going to be a 3-to-1 ratio here, but I would really need another set of strips to see if I see a pattern, okay? Any questions on that? Let's take a look at another. So on this one, I mean, I've got some really, really nice looking complexes there, don't I? They are beautiful. If I were a complex, I'd want to look like that. But then, I noticed that I've got some drop beats. So my atrial rate, 60, my ventricular rate is 40. This person's probably not compensating well. Y'all see it? One more. What about this one here? So you've got essentially, because it is computer generated, I would imagine on this, you've got essentially the same waveform that was giving y'all issue earlier.
That's a 1-to-1, it's skipping every other beat.
That's right. Because you see a pattern here. You know that your T wave is going to be wider than that. And you see a pattern. So yeah, so every other beat is dropped. Now, this is still a rate of 60, so it may still be sustaining, okay? But if it gets worse, then we're not going to sustain well. So our biggest issue that we're worried about with our lower degree heart blocks, our second degree heart blocks, is them progressing into a third degree heart block. Okay? So,
Can you show us the T wave again?
I mean, it's not really showing up right there, but it's right in there.
So that upward, would that be considered a T wave?
That's a P wave.
I know that one, but the one after that P wave that's missed, the QRS,
It's really kind of hidden.
So that's a P wave?
This is a P wave. That's a P
That's
wave.
how you know it's skip one, right?
Yeah.
There's no QRS.
so T wave.
So one of the things that y'all got to keep remembering is in your basic rules, some of the things that I taught y'all early on was you need to measure your regularity of your QRS and you need to measure your regularity of your P waves. Because if you do, you'll see that even though that may look a little bit different there, it is regular. But it's regular with drop beats or drop complexes.